As you are aware, New York City and New York State became the epicenter for the COVID-19 pandemic in the United States. So our hospital, which is a big hospital in New York City, along with other hospitals in the city, they were on the front lines of this pandemic. And leading up to it, that means, like I would say, in the early March, as we are kind of preparing for the pandemic, the hospital leadership, the department leadership under our chairman, Dr. Fink, our neurophysiology department leadership under Dr. Kandula, we made a lot of changes at many different levels to try to kind of be ready for this pandemic as it came. Predominantly, what the changes were done with respect to the neurology department was a lot of reorganization of the services which we offer, reorganization of both inpatient neurology services as well as outpatient neurology services. Most of the hospital was kind of resources were geared up to handle the COVID-19 pandemic. So leading up to this pandemic, all elective admissions were stopped, including the admissions to the epilepsy monitoring unit. And the unit remained open, but there were no admissions coming to the epilepsy monitoring unit. Patients who were scheduled for elective video EEG admission to the epilepsy monitoring unit were postponed. And there was a reorganization of the inpatient neurology resident service, attending service, and outpatient services. So all our outpatient neurology clinics, including the epilepsy clinic, which we have once a week, it's manned by the residents, the fellow, and one attending. They were all closed, and we kind of, went into a more of a telemedicine mode of maintaining continuity of care. What I can tell you is that the neurology department, under the leadership of Dr. Fink and Dr. Robbins, who's our program director, they really did a very good job. I can see from that way they kind of, the resident education continued. What did happen was everything moved online. So there were lectures being conducted through tele facility. For example, the speaker will be in one room, basically alone, presenting the talk via Zoom, and everybody could log on. So there was an effort made to try to maintain continuity of ongoing resident lectures, resident teaching, while at the same time trying to very hard to prevent exposure of anybody in the hospital. So then the reorganization service also was done to prevent the exposure of faculty, the resident staff, the administrative staff to the COVID-19. When it comes to subdivision epilepsy, we kept the epilepsy laboratory, our neurophysiology lab open, but we did have a little bit of reorganization of the lab. Again, predominantly the idea of protecting the technicians, protecting other staff. So the staff which could work remotely were working remotely, but the lab itself was open. So, we were doing, obviously, we are doing less of continuous EEG monitoring unless absolutely needed, and if it was needed for, it would make a difference in patient management. And there was more of a thrust of doing portable 20-25 minutes EEG study, get the information, give it to the clinicians, and maintain the continuity of care. With respect to outpatient epilepsy, we attendants made an effort to call all the epilepsy patients, especially the ones who have refractory epilepsy, hard to control epilepsy. We went over the charts, identified patients who had frequent ER admissions for status of breakthrough seizures, called a lot of them, put them on a rescue medication, like whether it's an oral lorazepam or intranasal midazolam. The idea was that we should prevent, having a patient being forced to come to the emergency department with status epilepticus for two main reasons. One, the emergency departments were packed with patients who had coronavirus, and the resources were being devoted to their care. And secondly, there was also a concern that a patient might get exposed to coronavirus if he or she lands up in the emergency department with like status epilepticus. So there was a thrust to try to prevent status breakthrough seizures from occurring in the first place by using rescue medications. And as you know, in epilepsy, there's been a lot of talk about rescue medications, different formulations of benzodiazepines. And I think this was one of the times when we really relied on those type of things to maintain, protect our patients from from coming to the ER. My comments are only what people probably, other doctors are experiencing. This pandemic, I think for me, it just taught me a lot about, even from a distance when I was looking at how the department was being reorganized, how the division was being reorganized, that there's a lot of planning which had to occur before the pandemic came. And then you also had to do a lot of planning during that pandemic. You had to think fast because things were changing rapidly. You had to have a little flexibility in reorganization of your workforce, reorganization of the neurophysiological facilities. For example, we do a lot of intra-op monitoring, and because when the pandemic happened, elective, we were not having much of elective surgeries being planned. A lot of the ORs had been converted into ICUs. So the intra-op monitoring, the volume really fell because there were no surgeries being done, especially elective surgeries. That's been done. The facility was still there. If we had a patient who need emergency neurosurgical management and they requested our services for intra-op monitoring, attendants and technicians were there for that. So I think it basically taught me a lot about reorganization and of trying to also be flexible to things to change according to the situation.